Good evening, everybody, and welcome to the fourth and final webinar of the East African Snakebite Symposium, a series that has provided us with valuable insights into snakebite throughout June. Through these sessions, we've covered critical topics such as snakebite epidemiology, the medically significant snakes in East Africa, snakebite first aid and snakebite prevention, an in-depth overview of antivenom and its uses, and the clinical management of snakebite cases. We are privileged to have had a series of expert-speaking clinicians and researchers whose extensive knowledge and experience have significantly enriched our understanding of these complex and vital subjects. At the top of the chat box, I have posted my email and the link to the webpage where I have posted the videos and PDF presentations that we've covered so far. For those of you not able to join the Daktari Online site, you can find it there. Please share this link widely. We want as many East African-based medical personnel as possible to have access to the information. It will also be posted on the Response Med and EMKF websites. Tonight, it is my great pleasure to welcome Professor Timothy Hardcastle to present. Professor Hardcastle is a distinguished trauma critical care surgeon and serves as the Director and Chief Specialist of Trauma and Burns at Nkosi Albert Luthuli Central Hospital in Durban, KwaZulu-Natal. He is also the Adjunct Associate Professor of Surgery and leads the Trauma Fellowship Training Program at the University of KwaZulu-Natal. Additionally, he is the Provincial Head of Trauma and Burns for the KwaZulu-Natal Department of Health and holds an Associate Research Professorship in Health Sciences at Durban University of Technology. His PhD focused on trauma systems in low and middle income countries. Professor Hardcastle is an influential leader in the field, serving as Deputy Chair of the UK University of KwaZulu-Natal, it's quite a mouthful, Ethics Committee, Chair of the same University Continuing Professional Development Portfolio, and currently holds the presidency of both the Surgical Research Society of South Africa and the Federation of South African Surgeons. He is a council member of the Association of Surgeons of South Africa. Beyond academia, he functions as the medical director for various EMS services and co-chairs the National Snakebite Advisory Group. His extensive publication record includes over 250 peer-reviewed articles, more than 30 book chapters, and numerous plenary lectures. He has supervised 37 masters and 3 PhD students, with more projects underway. His clinical interests span snakebite wound care, vascular trauma, trauma-intensive care, including blunt chest trauma, and trauma systems tailored for low and middle-income countries, as well as research ethics. Professor Hardcastle is an associate editor for 5 major international journals and actively reviews for several others. He also serves on 3 WHO expert panels. In his personal time, which I'm sure you can tell is pretty limited, he enjoys spending moments with his wife and children and relaxing by building scale models. Tonight, Professor Hardcastle will share his expertise on the surgical intervention and wound management following snakebites. This session will explore a critical aspect of snakebite management and the role of the surgical team, especially when dealing with cytotoxic bites. Topics will include initial wound care, definitive wound management, surgical interventions, and timing considerations. He will also address the conundrum of compartment syndrome and, more importantly, pseudo-compartment syndrome, including the necessary prerequisites before performing a fasciotomy in snakebite cases. Finally, he will discuss wound reconstruction and closure options. Thank you, Tim, for taking time out of your busy schedule tonight to join us. Welcome.
Thank you very much, Ellie, and to the East African Snakebite Symposium for the opportunity to share some insights with everybody. And I'm just going to say at the outset, I am also on call for the hospital. So if I suddenly put myself on mute and grab my cell phone, it's because there's a life or death call coming through, usually just approval of a transfer or something. But hopefully my team at the hospital will keep things under control. So without further ado, let's get to the matter at hand. So you've heard a little bit about me already, and you've kind of already heard what we're going to be discussing. So I'm going to take it in the order of some basic initial wound care, why we say no fasciotomy before antivenom, and including the issues around the role of ultrasound to exclude true compartment syndrome. We're going to discuss how to manage these cytotoxic wounds conservatively, and that's the sort of watchword: patience and conservatism. And then we'll look at the longer term wound care and how we close these wounds, whether we need to use antimicrobials, how to use them, when to use them, and here and there a word or two about pregnancy and children, but not in a lot of detail. I saw there were some questions on that at the previous session or 2 weeks ago. I was not here last week. And then I'm going to share at the end just the references which we use from the new South African guidelines, which were published in 2023. They don't necessarily include ECIS because so the carpet vipers, which we don't have in South Africa, but it's the general principles are applicable throughout Africa, I would certainly think. Okay, so let's move straight on to the basic wound care, and it's a case of do's and don'ts. So number one is don't tourniquet, and I think that's been emphasized repeatedly by many speakers throughout the course of these 4 weeks. The other do not is do not cut the wound, do not incise, do not suction, do not consider stone therapy, cryotherapy, traditional medicines, which may well include things that carry organisms and can increase the risk of infection. Again, the reason we say do not tourniquet is tourniquets obstruct venous and often not adequately arterial blood flow, so you end up with venous engorgement, and you can actually cause a compartment syndrome. So then there may be the need for fasciotomy. Most of the fasciotomies we do are because of unnecessary tourniquets rather than because of snake bites itself. Then the do's: do remove all the rings and tight things. Okay, so bangles, chains, tight clothes, these prayer knots that these guys, the little red prayer knots that certain religions wear around their wrists. Please remove them, cut them off, so that there's no obstruction to any venous, lymphatic, or vascular flow. Wipe away excessive venom with simple gauze or a clean tissue if you don't have gauze. Please do not use opioids, benzodiazepines for pain, because if it's a neurotoxic bite, these things potentiate the neurotoxic venom. And remember, most of these venoms act like muscle relaxants that we use in anesthesia. So they are potentiated by these opioids and the benzodiazepines. And then for the bites that we're focusing on tonight, which is the cytotoxic and tissue damaging bites, please avoid the use of non-steroidals. Okay, but apart from the fact that they increase bleeding, they have a significant potential for causing renal dysfunction, and some of the cytotoxic bites, because of their damage to the muscles, will lead to a myonephropathic syndrome, and that in itself can impair renal function. So on that basis, we prefer that if you're going to use something for pain, plain old paracetamol works well, acetaminophen for those that use the American terminology. And then if it's really severe pain, ketamine is a lovely drug, both for anesthetic and analgesic purposes. So what do we mean by cleaning this wound? Simple, clean tap water is effective for wound cleaning with soap. There's no difference in randomized trials between clean, well sterilized, or well, what's the word you use? Processed tap water compared to sterile saline in terms of the risk of wound sepsis. Yes, if you're dealing with unclean or water that's not purified, you may find that there are certain organisms that live in that wound or in that environment, such as the Vibrio species and things, and the Aeromonas. But that's a very small percentage. If you're using clean boiled tap water, it is as effective for cleaning the wound as using sterile saline, and it's a whole lot cheaper. If you're going to use an antiseptic, we strongly today, and I think the WHO will support this because their 2009 documents already said chlorhexidine is preferential to povidone-based antiseptics, so the iodine-based septics. Apart from the allergy risk, the problem we have in Africa is that our Pseudomonas, which is one of the commonest wound infectors in hospitalized patients, is innately resistant to povidone. And that is a huge problem. So if you're using iodine on wounds and they're remaining septic, that's why, is that the organisms are resistant to the iodine. So chlorhexidine, apart from that, it's more gentle on the tissues. So that's what we would prefer people use to clean the wounds with. Once it's cleaned, dab it dry, cover it with plain gauze, and then a loose fitting bandage to hold it in place. The neurotoxic bites are a slightly different concept, and the pressure bandages have been discussed both by Prof. Worrell and by various other speakers during the course of these 4 weeks. But as a rule, the plastic surgeons love putting all various ointments and things on wounds when they've washed them. They'll put mupirocin and all these anti-staphylococcal things. And what they don't realize is most of the time it's nice and keeps the wound moist, but it doesn't really do much because these wounds are actually not infective. So local wound care is the take home. And certainly within the first 24 to 48 hours, you don't want to do much more than that. Because if you do too much too soon, you end up with a lot of unnecessary tissue loss that could have been avoided. The dressings that you can use, there's so many different ones on the market, and if something as simple as a paraffin gauze can be used topically, but probably the best types of dressing to prevent sepsis are those that contain either silver or manuka honey. Those are two products that are naturally occurring and have a remarkably effective antibacterial preventative strategy. So if the wound gets infected, there's a different story. Then you need to look at possibly using systemic therapy. But for the wound that's been cleaned and it's just got areas of necrosis, it's still sterile necrosis, these other dressings are probably preferential. So something like Acticoat from Smith & Nephew or Aquacel Silver, which is a fiber dressing, and then the various gauzes that contain manuka honey. And for what it's worth, in lower and middle income countries, just good old normal bought from the store honey works just as well. We use that on our burns in our ICU. Okay, so that's the wound covered. Now you get the patient to hospital and everybody's very worried about, oh, this leg or this arm is so firm and swollen. Yes, that's the cytotoxic reaction. But most of the time, it is this concept of a pseudo-compartment syndrome. This was originally identified in the bites in the United States from the rattlesnakes, where it was first documented that the venom travels in the lymphatics. But it's been shown to be true for patients, certainly in Africa as well. And we have some really nasty cytotoxic snakes in this continent. We've got the Mozambique spitting cobras. We've got the various other spitting cobras that also are largely cytotoxic. And we've got the real nasty guy that you step on him before you realize he's there, the puff adders. And of course, in the rare bites that you might see from the Gaboon adder, which to my mind is still one of the most beautiful snakes out there, with its very long fangs, you will potentially have intramuscular bites. But this pseudocompartment syndrome leads to a lot of unnecessary fasciotomies. Most of the time in a snake bite, the damage is between the skin and the fascia layer, and doing a fasciotomy is not beneficial. It has the same signs and symptoms. The limb is swollen and stiff, and the fingers are stiff, or the toes are stiff. The ankle can't be moved. It's very painful. And that's when people who are used to dealing with fractures and orthopedic injuries and vascular injuries in particular, they see this and they say, oh, it's an ischemia reperfusion. The muscles are at risk. Unfortunately, the muscle damage from snake venom is a primary muscle toxicity caused by the venom. It's not from cell swelling. And it's best treated by antivenom rather than fasciotomy. Although the antivenom is often not very effective once this is present. So the first rule is before you think of grabbing a scalpel, and I'm a surgeon, but in snake bites, I don't like to cut. All non-surgical measures must first be exhausted. So the limb should be elevated, the appropriate analgesia given. Some people even advocate for diuretics. I'm not so fond of that because of the risk for the kidneys. Again, things like mannitol have recently been shown in the neurosurgical literature to also be primarily nephrotoxic. So anything that can harm the kidney, you try and avoid that. So first and foremost, you must evaluate the limb and see where the problem is. So one can, on the left, you'll see all the traditional tests for compartment syndrome. So there's the fancy striker needles that you have their sort of built-in pressure sensor, and you get this nice digital reading of what the pressure in the compartment is. But for the most part, even in South Africa, we rely on the good old manometer three-way tap system. Although we generally don't connect it to the three-way tap, we'll connect it to the arterial line transducer in the resus bay or in the ICU, and then pop in a needle, inject a small amount of saline just to get any air and plug out of the needle. You wait a couple of seconds for it to equilibrate, and then you transduce the pressure, and it gives you the pressure in the compartment, which then you can subtract from the arterial blood pressure reading, and that gives you your compartment perfusion pressure. And that's really what's the most important bit. But as we've said, most of these compartment syndromes are not compartment syndromes. They're pseudo compartment syndromes. And Daryl Wood, as part of his PhD at UKZN, he was working at Ngwelezana Hospital, which is the country's sort of top scoring hospital for snake bites. It happens to be in KwaZulu-Natal. So what he did is he took ultrasound, and he put the ultrasound on the affected or bitten leg, compared the subcutaneous space to the unbitten leg or arm. And you'll see on that slide where the big white arrow is, that's the actual compartment. The fascia is that bright white line where you see the two fine arrows coming down from the top. And you see on the left-hand side, on the bitten side, it's all subcutaneous swelling. It's the subcutaneous space that is expanded. The actual muscle compartments look exactly the same. So there's no compartment ischemia, there's no compartment syndrome. And you can avoid fasciotomy. If you're still, after doing all of this, are worried that this might be a true compartment syndrome, please remember antivenom first before you do a fasciotomy. The cytotoxic bites, many of them, and in particular the puff adder, as well to a lesser extent the Mozambique spitting cobra, have a hemotoxic component. And if you do the fasciotomy before giving the antivenom, the risk is significant of soft tissue bleeding, and that's not easy to deal with in many African hospitals. Okay, so this is the other way of doing it. Same story, needle connected via an arterial line set to the pressure transducer on your monitor. So we like to avoid the fasciotomy because, as I said, the venom effect is a primary necrosis that occurs. And again, this is what puts your patient at risk for renal dysfunction, which if you now do a fasciotomy and reperfuse that whole muscle more aggressively, you will end up having myocytes breaking down and myoglobin being transported to the kidney, and you end up with a crush-like syndrome. And it has a delayed recovery. There's always going to be some degree of functional loss, so the arm will be weaker, but it really doesn't have much of a difference in outcome whether you do a fasciotomy or not. Okay, so that's the important take home. So when you do have to do fasciotomy, there's the two examples. So this is on a child with a snake bite. This was from Nguelazan, and this was a patient with a puff adder bite of their forearm, where it actually went into the compartment. But you must first do the pressure measurements. And the reason I put these photographs in here is not to gross you out, but to just show you the extent of the tissue loss that you're creating by doing an unnecessary fasciotomy. Okay, so you're going to have this tissue, which, if you're lucky, the swelling will come down in a week or two, and you've got to try and get these skin edges together. Very unlikely to happen. Then you end up with a patient needing a skin graft on all of that tissue, with the resultant risks of surgical site sepsis, and contracture formation and so on. So after your first 48 to 96 hours, that's the time to start reassessing these wounds. So if you've avoided the fasciotomy, you've given your antivenom, which is for the significant cytotoxic bites from sort of puff adder, Mozambique spitting cobra, the other spitting cobras that are covered by antivenom, and the puff adder. You then wait and see what happens with these wounds. If you aggressively go and debride them, and I hate hearing about this from many of our plastic surgeons, they want to go and do early amputations on digits. Invariably, these digits will survive. They'll look horrible, they'll look black and swollen and blistered in the first 48 to 72 hours, and that settles over time. And by sort of around about day 5, day 6 post the bite is when you start seeing the tissue demarcating so that you know, all right, this is dead, that's partly viable and should recover, and that's uninjured. You can divide your tissue up. And the way to approach it is this thing called the time system, originally described by the guys from Smith and Nephew, but it's a very practical system. So you look at the tissue itself. Is the tissue viable? You look whether or not there are inflammatory and or infective changes. Most of the time, these wounds are sterile. Okay, studies that were done by Blaylock many years ago looked at a whole bunch of snakes. We took cultures from inside their mouths, and it was only in unhealthy snakes where they had significant organisms living in their mouths. So most snake bites will be fairly infection-free, but they will be inflamed. We don't treat inflammation with antimicrobials. We treat infection with antimicrobials. So rather send off a piece of the tissue when you do a debridement and culture the tissue rather than just a wound swab. And if you're going to do a wound swab, make sure that you clean the area first before taking the wound swab. Otherwise, all you end up growing are your colonizing organisms. And that's not necessarily what causes the infection. The third aspect is the moisture balance. We know now from the last 10, 15 years worth of wound care research that slightly moist wounds heal better than dry wounds. Okay, so the old concept of, oh, let it scab and dry out and it'll heal, that actually takes longer to heal your wound than a wound that has got a good moisture balance and allows epithelial cells to actually move over the surface of the wound. It also allows macrophages and white cells to come into the wound and deal with any inflammation and infection. So ideally what you want is you want edge margin response or epidermal advancement. You want to get the skin that you've lost to grow back, or you might have to replace it. So those are the four aspects that you look at, and then the acronym is TIME: tissue viability, inflammatory changes, moisture balance, and epidermal advancement. So here's an example for you of a Mozambique spitter bite that we had in our ICU. This was a 8 or 9 year old child, and you can see initially on the top left, big blisters, looks terrible, but by a couple of days down the line, on the right at the top, the majority of those wounds are starting to heal and granulate already. We've debrided the blisters, and you can see that this patch on the top of the foot was undergoing full thickness necrosis. And on the right at the bottom, this was on day 8. You can see nicely now exactly where you have to go and excise. That little black patch is what we call eschar, and that's the only bit that we had to debride. We made sure that we skin grafted it immediately, and so that the tendons were covered, the underlying tendons were healthy. And this is a good example of why it's important to be patient with your management of these wounds, and don't rush in. So if you'd rushed in and on where the picture was at the bottom on the left, you would have probably ended up excising all the skin from above the ankle almost to the toes. But by waiting a little bit of time, you ended up with a much smaller excision, much less inflammatory changes at the time of operation for the child. Okay, so we do advocate that blisters should be debrided early, and the reason for this is that they contain serum, which may actually contain inflammatory products that therefore increase the risk of ongoing inflammation. So we advocate these days for thin-walled blisters to be debrided. If you've got really thick-walled blisters that are nice and intact, you can maybe leave them until 96 hours to mature. But most importantly, it's all about having patience, letting time take its function to demarcate your tissue so that you can see what's there. And once you've done that first week of being patient, that's when you can take these patients to theatre, you can debride the dead stuff, and then if you can't cover it immediately with split skin graft or something, then we advocate the use of negative pressure wound therapy devices. So again, there's lots on the market, but you can also very cheaply make these on one's own, as long as you've got a negative pressure wall suction or a suction unit in the ward, and you've got some suction tubing, and you've got some opsite or similar sticky dressings, you can make your own negative pressure wound therapy. And the reason that this works is it helps the tissue to granulate, and then it gives you a nice clean wound bed that you can eventually go and place skin grafts on, probably around about day 10. So here's another example of a case that we had, and the dates there are, so just to give you the timeline. This was a Actraspis or stiletto snake bite. This is probably the commonest cytotoxic bite that we actually see. I saw 3 different bites from 3 different snakes on one particular day in the summer months. So basically, the guy got bitten on the 5th of October on his thumb. He was seen by one of the plastic surgeons in the private sector who said, "Oh, that thumb is dead. I want to amputate it." And suffice to say, he wasn't very happy with that idea, and decided to make his way to our hospital when he heard that we have an interest in snake bites. So he came to us, and on day 3, day 4 post bite, so the fifth was late, early morning is when he was bitten. 8th of October in the afternoon, he came to us, and we debrided the blister, and lo and behold, there's good, healthy, sort of beefy red tissue underneath there. A week later, you can see it nice, like pink and healthy, started granulating. The only bit of the finger that was still a little bit black was the tip. A couple of days later, even the tip had normalized. By the 18th of October, so 2 weeks or so down the line, you could almost not see that there was much of a bite injury. It looks like he had a bit of suntan or a superficial burn. And a week later, he came back to us and said, "Look, the only bit that was left was this very tiny bit of necrosis. It was less than a centimeter by a centimeter on the tip of the thumb, which we excised under local anesthesia, and primarily closed. And he ended up saving his thumb with full function. So this is the concept behind conservative surgical management. All right, so a bit more detail about the TIME, so the tissue viability. So for your debridement of tissue, use a sharp debridement. So scalpel and a pair of forceps, obviously under appropriate anesthesia or analgesia. It depends on what type of facility you're in. If you're in a big regional facility, you might want to take the patient to theatre if it's lots of debridement. But you can do it under a regional block. You can do it under a ring block for a finger. But the important thing is take the scalpel, take the forceps, cut back to healthy bleeding tissue, and that's where you stop for the first debridement. Make sure that you have good hemostasis. Ideally, in theatre, you'll have access to a cautery or a bovie, as the Americans call it, to enable hemostasis to occur. And it's all about gentle tissue handling. So you don't want to cut away anything that looks like it might survive. In terms of the moisture balance, we've said we don't want wounds to dry out. Dry wounds take longer to heal. There's various products on the market. The one that we like to use as a pure moisture gel is something called Intrasite. If your patient presents late and they've got very sloughy tissue, or if they've got the risk of having had a bacterial biofilm form on the wound already, then you can use either Iruxol, which is a chemical debrider. It contains enzymes from bacteria, and it helps to digest the dead stuff. Or you can use something like Prontosan, or there's a couple of these on the market. They break down the biofilms so that the organisms are exposed and the dressings can then get rid of the organisms. Ideally, you want an occlusive dressing because that keeps the moisture in, and you want to have the dressing of a sufficient absorptive capacity that, depending on how much slough and moisture there is, that the dressing absorbs excess moisture but keeps the wound bed just nice and moist for granulation to occur. As this happens, and as your dressings become less regular, so in other words, initially you'll maybe change the dressings every 24 or 48 hours. Maybe as the wound becomes healthier, you'll change that to sort of every 3 days or so. And that's the time, if you've got a very big surface and you've got lost some of the dermis, you might want to use something like Promegran or these synthetic dermises that you can then allow the tissue to grow into those synthetic dermises, so that when you take it's covered with a silicone layer, and you take the top silicone layer off, it's ready for skin grafting. These dressings also are antidotes to the metallomatrix proteases, which are enzymes that break down wounds and delay your wound healing. Right, so as I've said, the vac dressing, the suction dressings are very easy to make. This is the commercial one that I'm sure many people have seen photographs of, but here's the easy way to make your own. So a layer of Gelinet or Adaptix, so one of the paraffin impregnated gauzes, you put that on top of the clean wound, and you take any kind of sponge. You get sponge from the local guys that make bed mattresses. Put it through your autoclave, sterilize it. I mean, you can buy them from 3M, you can get them from the commercial companies, but any sponge will do. You can even use abdominal wound gauze, nicely put together. Pop that on the wound, then you place an occlusive dressing, so these sticky plastic dressings, Opsite, Ioban, Steri-Drape, whichever one you have, Tegaderm, there's so many on the market. They all compete for pricing and so on. You place that over the sponge and on the edge of the wounds. As you can see, it covers onto the healthy tissue. You cut a little hole somewhere in the plastic, and through that, on that, you connect your celastic or suction catheter tubing, and then another occlusive dressing to hold it in place, and you connect that to either your suction device or your wall suction in your hospital. And so here's the principles behind it. This is the commercial one. So you put the sponge on the wound, you cover it with its sticky bit, put the suction catheter on, and connect it to the wall. And this is how we do it. This one is with gauze. This is obviously after a laparotomy wound that had some superficial sepsis. We took out the skin sutures, put a layer of paraffin gauze and then some normal gauze and a normal suction catheter that you use for suctioning endotracheal tubes or babies' pharynxes when they're born. And that's connected to the wall suction. We adjust the setting so that it's at around about -20 to -40 millimeters mercury. You'll see it sucks the dressing down, sucks off all the mucus, all the slough, and all the infected stuff, and it stimulates through negative pressure the ingrowth of vascular structures, so microvascular infiltration. It stimulates granulation tissue, and it gives you a lovely, clean, healthy wound bed that can be skin grafted soon thereafter. The other options include the include the more modern wound dressings. Oh man, why is it hopping? There we go. Let's just move there. I'm struggling to see because I've got all the cameras and things facing my screen. So the enzymatic debridements we've mentioned, there's the collagenases, there's Santal, and there's Iroxol. One can use benzoic acid, which sometimes works for debridement as well. And then there's these various other dressing materials. This green one is called Sorbact. It's available. It's designed and manufactured in Africa, and it's for Africa. We use it for burn wounds, but you can use it for other superficial wounds as well. The mesh contains a substance that draws in slough and draws in bacteria and locks it into the dressing so that the wounds don't become infected. The Surdac, which uses a bioceramic material, works in a very similar way. So these are all products that are going to help you get your wound bed ready for skin grafting. And then skin grafting is usually going to be in the form of split skin grafts, either with a dermatome or a Humby knife or one of the other superficial excision knives. The donor site is usually on a lower limb. I try and take the donor from a portion of the limb that's going to be less obvious if someone wants to wear a swimming costume, for example. Then once the skin is taken, it's called a split skin graft because it's taken below the epidermis but above the hair follicle level. And so therefore the skin regenerates from the hair follicles, and that's why when it's busy healing, it looks like a whole lot of little black dots that are coming together and healing the tissue. Then you take that piece of skin, put it through a meshing device, which makes little tiny holes in it, and you can see it in this other photo on the right here, where the tissue is growing in between the little perforations. Those perforations are there to allow edema and effluent out of the wound so that you don't get a seroma underneath the skin and lose your skin graft. Most of the time today we fix them in place with skin staples, but there are people that use good old over-the-counter hardware shop super glue. Works just as well. You just drop it on top of the edges of the graft, and that holds it in place. So in Africa, we have to make plans to do things, as we call it, the MacGyver way, and that's one of the MacGyver ways to keep skin grafts in place. All right, so to end off with, these are the four references, four papers that were published in the South African Medical Journal in 2023. There's an introductory editorial that I wrote, and then a group of us got together and wrote each of the various aspects. So there's a paper for laypersons and emergency medical services, and that's largely about the first aid management. There's the hospital phase, which is what do we do once the patient arrives in your emergency department. And then there's a section on surgical aspects, special groups, which was the pregnancy, the children, and ophthalmological injuries, as well as a very useful document that people could use to document snake bites, so that you have an accurate record, and it kind of gives you the hints of, have you done the 20-minute blood clotting test? Have you done this? Have you done that? So that like the World Health Organization surgical checklist, it gives you a snakebite checklist. So those are available from the South African Medical Journal, which to most countries in Africa is free full text online. So you should be able to access those wherever you are in Africa. And I'm happy to take questions. Thank you very much.
Thank you so much. That was absolutely fascinating. Really, really interesting. I learned tons personally. We do have a couple of questions for you. We're just going to put a little test up on the screen for everybody, just to make sure you've been listening over the last 3 weeks. And as we wait for the results, we'll give you a few minutes, 4 minutes to fill that in. And as we wait for the results to come in, we'll go back to Professor Hardcastle with some direct questions. I have a few outstanding questions that haven't been answered. So Lily, if you'd like to put the poll up on the screen, and if you could all just give it your attention for the next 3-4 minutes, and it will give us some discussion topics for our post-talk discussion. Thank you.
Could I ask a question, please, Ellie?
You carry on.
Tim, that was masterful, and a lot of very useful detail, practical detail about what to use in these different situations. I've only got one very humble point as a non-surgeon, and we've discussed this before. I think in good surroundings, in good sterile ward surroundings, I would agree with you, there are probably arguments for de-roofing, debriding blisters. But in the conditions which I'm more familiar with in some parts of Africa, a sort of fly-strewn, rather dusty wards, I'm rather in favor of leaving the blister wall on and aspirate. I agree with you, you should remove the contents which do contain some venom, and they also risk, if they're very tense blisters, they sort of risk getting exploded if they're pressurized, making a terrible mess and adding to the general fly attractiveness of the bed. So anyway, for all those reasons, I prefer fine needle aspiration of the blister contents, so that you're leaving the blister wall on as a sort of wound protection rather than denuding that rather large area of dermis.
Yeah. I mean, if I would agree, if it's and particularly I made the comment that if it's a nice firm walled blister, that you can leave them alone. But the problem is a lot of the blisters are quite flimsy, and then they do pop, and that dead skin then becomes a potential source for sepsis. So that's why I like to take the dead skin away. But your point is well taken and needs to obviously be applied as to whatever the surroundings are that people are working in.
So I have a couple of questions for you, Prof. Somebody has asked, is there therapy for a wound that has not healed for many years?
Well, it would depend on what the extent of that wound is. But yes, I've had a number of cases over the years where people have come to me and said, oh, it's been, well, maybe not years, but certainly a good few months, 6 to 9 months, where wounds haven't completely healed. And usually it's because they might have granulated partially, but there's some necrotic tissue somewhere that needs to be excised. And once the debridement has got rid of the dead stuff, then all of a sudden the wound will start healing. There is a risk with long-term wounds that don't heal that they can undergo cancerous change. The traditional name for it is a Marjolin ulcer, classically described in chronic burn wounds. So one has to also, if it's many years down the line and it's still a persistent wound, should have a biopsy just to make sure that it hasn't undergone some cancerous transformation. Yeah, and then otherwise it needs to be seen by a surgeon, and this is probably where the surgeons would call in the plastic surgeons to try and help get tissue cover.
Okay, thank you. Someone else asked, should the suction be continuous when you're doing.
Yeah, I did type an answer in for the chat for that one.
Oh, sorry.
Yes, the idea is that some of the commercial products, the Renesis from Smith & Nephew, for example, as well as the KCI VAC, the traditional VAC machines, have an option for an intermittent suction. But that's because they're using these fancy suction tubings that regulate the pressure. If you're using the self-made wall suction device, we generally just keep it on at the low pressure suction, somewhere between -20 and -40 millimeters mercury, and leave it on. We generally advise the dressing to be changed every 3 to 5 days, but if the dressing itself, the top dressing, remains nice and clean, we've left some of them as long as 10 days before changing them. And it's low pressure suction. It does, sometimes patients complain a bit about itching and a bit of superficial wound pain. Most of the time that responds to paracetamol.
Thank you.
Tim, could I,
Lily, can you? Oh,
Tim,
sorry.
could I jump in with another question there, very, very
Sure.
naughtily? I'd really like your advice about the problem with hypertrophic and keloid scars, which can, even though you've got a nicely healed wound, can sometimes cause considerable dysfunction after the bite.
Yeah. So, I mean, that seems to be a genetic predisposition in certain people to develop keloids. So keloids are one thing. Hypertrophic scar is a bit more generally problematic. And the main way to prevent that is, once you've got skin grafts and things done, is a combination of triamcinolone steroid injections, if you see it occurring, and the use of pressure garments, which were obviously pioneered in the burn wound recovery phase. So those are the two things that if we see a wound starting to suggest that it's headed for hypertrophic scarring, we'll do early triamcinolone injections and combine it with pressure garments. The keloids, on the other hand, are far more pathological. And the problem with the keloids, unlike the hypertrophic scar, which will slowly heal over time, the keloids recur if you go and excise them. And that's a real challenge. It's one of the sort of banes of the plastic surgeon's life, is the keloid. So, and they can be quite progressive, whereas the hypertrophic scar generally gets to a point where it stabilizes, and then you can either excise it or do flaps and so on to try and cover it. But yes, it's quite a conundrum, unfortunately.
Thanks.
How to approach thromboembolic events following snakebite?
I would say that it's the same as any other thromboembolic events in any hospitalized patient. There's no contraindication after the first 24 hours to start these patients on low molecular weight heparins or subcutaneous heparins. They need to be mobilized early. If it's on the lower limbs and it's on the unaffected limbs, I would advise the use of calf length only active compression stockings. If they're supine and bed rest, those don't work very well. There you've got to kind of use these calf compression pumps. But it's no different to the management of thromboembolism prophylaxis in any surgical patient.
Okay. Is it safe to use Manuka honey dressings in diabetic patients? They say
Yes.
delaying diabetic patients.
Surprisingly enough, yes. As a matter of fact, a lot of the first work on Manuka honey, which comes from Australia originally, was done on diabetic foot sepsis.
Cool, thank you. I think you covered this already about biological debridement. You were talking about using things
Iraxol, yeah, there's a couple, there's 3 or 4 different products. Iraxol is the one we have in South Africa. There's 3 or 4 different chemical debriders on the market.
Okay, there's questions about the use of antivenom, but I think we'll come back to that. What's your opinion on use of IV flagyl in cleaning and dressing of wounds?
Not routine. If you're in an area where anaerobe infection is particularly a problem, then there may be a place for actually putting some metronidazole into your irrigation fluid for the topical wound care. It works topically as well as systemically. The other important thing is, unless you're dealing with amoebiasis, there's really no benefit to giving more than 72 hours of metronidazole intravenously. It will have done its job by that time. So I would say only on indication and certainly not routinely.
Tim, that comment about biological debridement reminds me of using maggots or even leeches. And I know
I didn't want to go there, but yes, that is an option.
it sounds disgusting, but it actually can be, in the right hands, it can be a very clean way of debriding a really nasty necrotic wound.
Yes, indeed. No, we actually are at the point where if a patient comes with a wound that's got maggots on it, we put a covering dressing and let the maggots do their job, and then 4 or 5 days later, wash them off, and you've got a nice wound bed. So it works.
Yeah. I'm sure you covered this, and I'm sorry because I'm answering questions. I can't concentrate fully. But what scenarios would amputation be considered? I mean, I think that's what you've just basically said. It's the last resort, essentially.
Yes. So certainly not in the early phase. There may be patients who, particularly with lower limb bites, have such bad muscle necrosis, not from a compartment syndrome, but from primary envenomation. And this is particularly, I've seen it with the Mozambique spitting cobra, but I've also seen it with a significant puff adder bite, where despite all the right things, elevation, anti-venom, and timely anti-venom, the patient still ends up with a dysfunctional muscle, and they potentially go on to develop something similar to a Falkman's contracture. And in that case, occasionally it's better for the patient to have the limb ablated. But just doing early amputation of fingers and toes because they're looking black and blistery is not advocated.
So what is the primary goal of WHO's 2030 roadmap on snakebite envenoming? Good to see that just over 80% of you got that right. Indeed, it is to reduce global deaths and disabilities from snakebite by 50% by the year 2030. The next question is about a 24-year-old farmer who was bitten on the leg while working on the field. And this is about basic first aid and what you can do for a patient or a victim to help them as early as possible. 85% of you got this answer correct. Is there anyone from the panel that wants to add anything to this? About the basic first aid for, I see that there are still questions coming back in about the black stone and the use of traditional medicines. Does anyone want to quickly go back to that for?
Well, I'm happy to talk about that. I mean, I think that we all realize that traditional therapists do have some experience, and they often occupy a very respected position in the community, and one should handle them politely, even though you may be appalled by the effect of their treatments and the delay that their treatment imposes on our patients reaching medical care. Having said all that, I think there's been extensive review of all these popular modalities. Tim mentioned some of them in his don'ts. For example, any sort of sterile incision at the site of the bite, whether it's to allow you to stick on a black stone or not, and rubbing herbs into the wound, contaminating the wound in any way is bad news and may actually increase the risk of necrosis. So it sounds very arrogant, particularly from someone speaking from Oxford, UK, to say that traditional treatments have no proven benefit. I'm still hoping that one day a traditional treatment will be demonstrated to have benefit and not harmful effects. But so far, the overwhelming published experience of critical observers is that traditional treatments are harmful and have no benefit. But I do apologize if that sounds very arrogant and a gross generalization, but that is my honest impression. So I would very much discourage traditional treatments.
Thank you, David. I think the long and the short of it is the most important thing is to get your victim to hospital as quickly as you can. And if you can immobilize the limb with a splint and apply a pressure pad with a bandage, all good and well. But timing is of the essence here, and getting your victim to hospital is as quickly as possible is your best bet. So the next question, why is early identification of envenoming signs crucial in the emergency setting? And the correct answer is it helps guide supportive care and antivenom administration. And that goes back to what we've just discussed about first aid. You know, your most important thing is to get your victim to hospital as quickly as you can. Which of the following best describes the clinical significance of neurotoxic snake bites in East Africa? We did go through the envenoming syndromes. Does David Williams, do you want to touch on the envenomation syndromes of the snakes?
Well, I can't quite see the number of answers there. Let me just scroll up and find it.
You got 77%. So we have 3% who thought it would cause kidney failure, 19% that think it would lead to extensive tissue necrosis, 77% who went with the descending progressive paralysis and respiratory failure, which of course is correct, and 1% said delayed bleeding.
Yeah, so I mean, the thing here is that neurotoxins, by their name, apply to nerve and muscle signaling, the messaging from the nerves to the muscles that enable us to move, to speak, to breathe, to poke our tongue out, to smile, all sorts of things. And so the clinical significance for neurotoxic snake bites, the one thing that best describes it is descending progressive paralysis. In other words, the first things you probably notice is paralysis of the cranial nerves that eventually in very long envenomed patients may extend to the peripheral nervous system and prevent them moving, so their fingers and toes. But generally the most dangerous is going to be the effect it has on the cranial nerves, the nerves around the mouth and the throat, and of course the muscles around the chest and that deal with breathing and respiration. So those are the things that are most noticeable and have most clinical significance with neurotoxicity.
Thank you very much. And moving on now to the viper envenomation, the most common signs of viper envenomation, which is obviously a cytotoxic bite. 12% answered dry mouth and dilated pupils, 3% visual hallucinations, 73% correct, painful progressive local swelling and tissue injury, and 12% bradycardia without hypertension. And I think Professor Hardcastle's talk tonight has been all about how to manage that swelling and the tissue damage in order to avoid amputations and fasciotomies. Is there anything you want to add to that, Professor Hardcastle?
In the early phase, early elevation of the limb, for the cytotoxic bites, no compressive dressings, early wound care, and then wait and see. Antivenom as soon as you realize that it's one of the bites that qualify for antivenom, and then take it from there. conservative debridement.
Great. What is the role of paracetamol in snakebite management? I think this question is important. It's come up a lot. The use of corticosteroids or non-steroidal anti-inflammatory drugs in the treatment of snakebite, and everybody that has presented has clearly advocated against the use of any analgesia except paracetamol. And I'm glad to say that 96% of you were listening. So that's really good news. And I think unless anybody has any questions about that, I think it's been made very, very clear.
Alison, can I just drive another nail into the coffin of non-steroidals?
You may.
Tim has emphasised the potential for causing acute kidney injury. I have emphasised the problem with bleeding. They inhibit platelets and so on. But there's a third very well documented effect, which is to enhance some infections, particularly probably the most dreaded infection, which is fasciitis, necrotizing fasciitis. It's one of the most dreaded infectious syndromes, both for surgeons and physicians, because this is a case where physicians and surgeons just must act together. And there's quite a lot of evidence now, I think suggestive evidence, that non-steroidals may increase the risk of necrotizing fasciitis, particularly diclofenac is the one.
Yeah, I was about to say diclofenac's the nasty one there, and it's because people use it intramuscularly, and then it causes a muscle necrosis and a spreading fasciitis. Our HPCSA has a policy that if someone gets necrotizing fasciitis after a non-steroidal injection, there's no defense. It's an automatic guilty. The minimum fine is 20,000 Rand.
Wow. I see Dr. Williams is answering a question, but I thought it was quite an interesting question that we could put to the panel. If one is bitten by a neurotoxic snake and requires ventilating, how do you limit the distress, or do you need to limit the distress? Sorry, David, I didn't see what you answered.
Maybe I can also add something there as an intensivist. So if we have patients on ventilators, we will use ketamine together with possibly dexmedetomidine as the sedations of choice. So ketamine is great because it gives you blood pressure support, it gives you analgesia, it gives you sedation, and also increases a little bit your lung secretion, so it makes them easier to suction out. So it's really the ideal drug. We almost use it, and it's safe in head injuries as well now. So we use it in our ICU as our primary analgo sedative for ventilated patients. The good news about ventilated patients with snake bites is if you give them antivenom early enough, they very seldom need to be ventilated for more than about 48 hours at the very longest. They reverse their paralysis very quickly, and those with cobra bites but not mamba bites may also benefit from the additional use of neostigmine and either atropine or glycopyrrolate, because it helps restore the neuromuscular and neural synaptic junctions. Same as reversing anesthesia. That's the principle.
So interesting that this is still not fully understood, and something that I think is really important. What is the correct primary drug treatment for anaphylaxis? 34% of people answered hydrocortisone and antihistamines, 5% hydrocortisone on its own, 54% only answered adrenaline, and antihistamines alone was 7%. The answer is, of course, adrenaline. Does anyone want to add something to that?
Well, I think the problem here is that a lot of people, a lot of doctors and medical workers are frightened of adrenaline. Those who've read a lot may have detected that there is a very small risk that adrenaline can raise blood pressure and possibly cause harmful effects by causing a surge in blood pressure. But I would say overwhelming global experience is that the benefits of adrenaline in anaphylaxis, which is one of the most acute life-threatening emergencies that can face any medical person, the overwhelming evidence is that adrenaline is a life-saving drug, and it's almost miraculously directed at various aspects of the anaphylactic reaction. It doesn't just do one thing, it does 3 or 4 different beneficial things, which in most cases of anaphylaxis that I've treated produce a rapid resolution. Now, the danger of adrenaline is you shouldn't just jab it in intravenously, and you should be a bit circumspect about what concentration of adrenaline you're using. But 0.1%, that's 1 in 1,000 adrenaline solution, can be given safely by intramuscular injection. And I'd recommend a muscle that is bioavailable, that's a technical word for allows the absorption of drugs. So the lateral side of the thigh is recommended. And the approved dose, you can't do any harm in an adult by giving 0.5 mLs of that 0.1% adrenaline. And it is literally life-saving. It is one of the sort of short list of really essential drugs that one want to have in an emergency pack. And I'm really disappointed that people still talk about hydrocortisone. You remember David Williams dismissed it summarily by saying that any beneficial effect of steroids in anaphylaxis are going to be delayed by many hours. And even the idea that they would steroids would prevent recurrent anaphylaxis has been largely rejected now. And antihistamines, frankly, cosmetic. They're certainly symptom relieving, because a nasty itchy rash is one of the most unpleasant mild manifestations of anaphylaxis, and antihistamines will deal with that. But antihistamines are in no way life-saving. And the priority drug here is adrenaline, adrenaline, adrenaline. We have to reassure people how it can be given safely and encourage them to give it at the first sign of an anaphylactic, for example, anaphylactic antivenom reaction. I hope I haven't overstated that, but it's very frustrating having taught generations of emergency room doctors in this country and others, in the United Kingdom and elsewhere. There's this reluctance to use adrenaline, which I think is quite extraordinary.
Yeah, I can only support that and emphasize it. The latest South African Research Council protocol, the latest UK Research Council protocols for anaphylaxis have both removed antihistamines and steroids from the protocols. So it's now about get IV access, give the intramuscular adrenaline. If that doesn't work, start an adrenaline infusion and give the patient 20 mils per kg of crystalloid to support them. And the adrenaline is intended to raise the blood pressure, because one of the things that happens during anaphylaxis is vasodilation, and you lose your blood pressure. So there's no problem in that regard. The other important thing to remember about adrenaline is we advocate for 0.25 milligrams, which is 0.25 mils of a 1 in 1,000 subcut before your antivenom is given. It reduces the incidence of antivenom reactions in the first place. There's 2 big randomized trials from India which both showed it, and I must admit, since we've implemented that as part of our South African protocol, we've reduced by almost half the amount of antivenom reactions that we've seen. So subcutaneous before the antivenom, intramuscular if you have a reaction and anaphylaxis, and then intravenous if the patient needs organ support longer term. Is a way to remember it.
Thank you very much. I think that's very clear. So what is the major reason for poor...
Yeah, it's David here. I'm just going to butt in for a minute. The only other thing that should be added to that is that a single dose of intramuscular adrenaline in an anaphylactic reaction, anaphylaxis, may not be enough, particularly if it happens to be a big person like me. And I know this from direct experience. It may take multiple doses to bring it under control.
Yeah, you can repeat every 5 to 10 minutes if necessary.
I think that's an important thing for people to realise.
Thank you. So the major reason for poor outcomes in snakebite victims in East Africa, as everyone can see clearly, is the delay in accessing appropriate medical care, which goes right back to sharing this information with our community health promoters, sharing information with patients once they've been bitten to take back to their community members, and for everybody to understand that a snakebite is a medical emergency. And the quicker you can get people to appropriate medical care, the more likely they are to have a better outcome. And then I think this question with regards to running this symposium and, you know, trying to make a plan for a better outlook is, you know, what important steps should be implemented by our governments in East Africa to gain a better understanding of the burden of snakebite. And all of those answers are correct. You know, we need to improve access to and our supply of antivenom. We need to make snakes a notifiable disease so that the understanding is way better, and we need training. And this is what we've hopefully started here, and the WhatsApp groups and things that we've created are a way of keeping the conversation open and hopefully continuing on that journey to improve the outcomes for snakebite victims. I am just going to open the floor to anyone in the panel that wants to add anything before we start our closing. Perfect. Well, I will, on behalf of the Taylor Ash Anti-Venom Foundation and Watamu Snake Farm, I'd like to thank you, the panel, for your time, your knowledge and experience, which you have so generously shared with us over the last 4 weeks. We are extremely grateful to you all. I'd also like to take the time to thank you, our audience, for signing in every week in numbers that quite honestly well exceeded our expectations. Thank you for your thoughtful questions and your time. I hope that the East African Snakebite Symposium has delivered what you had hoped for, and most importantly, I hope it has provided you with the practical knowledge, no matter where you are working, to help communities with snake awareness, snakebite prevention, and to encourage positive health-seeking behaviours in the event of a snakebite. For the doctors and nurses who are dealing with snakebite, I hope you feel empowered and better able to tackle this terrible, neglected tropical disease. Please remember that please remember to keep a record of our contacts, and we're always available for advice or identification of a snake through our WhatsApp group. All of the presentations, PDFs, the videos are available online. They're available through Daktari Online. They're available through our website. They're available through ResponseMed website and EMKF website. So everyone should have access. And my advice to you would be, please go back and listen again, because there's been so much information and some people have taken it on board, but others have not. And there's still a lot to learn. So please, please go back, read the presentations again, listen to the videos again, and let's try and improve what we're doing for our snakebite victims. If this has sparked an interest and you want to learn more, we do run a comprehensive 1.5-day training focused on snake identification and safety. And additionally, we're able to offer an optional half-day module with Dr. Eugene Urulu, which covers clinical management of snake bites for more in-depth knowledge. I have put my email in the chat group. You can go to our website and find our email. Please contact us if that's interested. We are a non-profit organization, and these trainings do help us to generate funds necessary to support our community work. However, we are committed to expanding our outreach, especially to communities that are most affected by snake bites. We would love the opportunity to bring this training directly to community health workers in high-risk areas. So if you're on this call and you have an organization or a business that's interested in supporting this initiative, please reach out to us via email, and we'd be delighted to discuss how we can collaborate to make a difference. And finally, I'd like to express our heartfelt gratitude to our sponsors, ResponseMed, Africa Health, AMREF Healthcare Africa, Emergency Medical Foundation Kenya, and the Global Snakebite Initiative. Their generous support and commitment have been instrumental in making this symposium possible, and their dedication to improving snakebite care and awareness has truly had a profound impact on our community. Thanks to their partnership, we've been able to disseminate vital knowledge, foster collaboration, and inspire action across a diverse audience. I'd now like to invite Diana Carson from ResponseMed, our headline sponsor, to share a few words.
Hi, good evening, everybody. Ali, thank you very much. And congratulations to you and your team for pulling together such an impressive 4 weeks. I think you really have, you've brought the world's specialists to everybody who's registered and participated. And to the panel, thank you all very much for sharing your years and years of experience and knowledge and insight. I think all of your practical case studies and learnings were incredibly beneficial for everybody. I'm happy to report, to Ali's point, this symposium has obviously communicated that there's a very big need for more knowledge, and it's exceeded our expectations in terms of registration numbers, but also in terms of geographical reach, where we were tallying up earlier, we've had people joining us from 56 countries around the world, and 26 of these countries are in Africa. And I think that's incredible. And thank you to all of you for sharing your insight, and to all of you who joined us from those countries, because I think the more people we have who are aware of this content and who are able to help share it and disseminate it to the community healthcare workers will help us win the battle that we're all trying to fight. So many thanks to all of you. And as ResponseMed, it's been a pleasure working with you, and we look forward to continuing to work with you on future initiatives. AMREF have been a co-sponsor of this event, for which we are also very grateful. And I would like to hand over to Charles to say a few words just off the back of us wanting to do more in the private-public sector engagement space across the continent. Charles, I look forward to working with you and the AMREF team, together with Watamu Snake Farm, on many more snakebite initiatives going forwards.
Thank you very much, Dan. Thank you so much. I'm truly impressed by this symposium. I mean, I participated in the first one. Unfortunately, I didn't participate in the second or the third, but in joining on the fourth one, I learned a lot. I listened to Professor Hardcastle, the detail of the work, the kind of work that he does with regards to snakebite wounds and healing and treatment. And it occurred to me that this is not something that is cheap. This is something that is obviously costs a lot of money and a lot of resources to do. I started thinking as well, though, that this is an initiative on snake bites that we really must get engaged in. You know, in 2004, the mortality, the number of deaths from HIV was approximately, according to the World Bank, almost 2.2 million people per year. But by 2023, that number had dropped down to about just over 600,000 deaths per year. Now, HIV in Africa and the world was given a lot of priority, and is still being given a lot of priority and attention. Unfortunately, the snakebite issue, which causes a lot of deaths, and where data is missing and where information is missing about the number of people that die, the impact of snake bites is still not well developed. So to my mind, we have a lot of work to do. I think we have work to do, as has already been mentioned, in the areas of communication, greater awareness, greater prevention. With regards to HIV, for example, there was a very simple slogan in Botswana, championed by the president of Botswana at the time, abstain, be faithful, condomize. It seems so trite and so banal, but it was trying to drive as effectively a message about how, in practical terms, you might be able to resolve or prevent some of these issues. I started thinking as David was, as Timothy was speaking, and Sir David was also speaking, that the type of treatments that they talk about and the way that you have to do these things with such detail. I wonder about the people in rural areas with low levels of income, low levels of understanding of these medical techniques right there in villages throughout the continent, who might not understand, who certainly don't understand these methods. And it's, to my mind, there that we have to put a lot of attention, and we have to get greater awareness and transfer that information so that, for example, the point that Sir David modestly made about, why would he, it might come across badly for him to say that traditional methods don't work. But he's absolutely right to say that in the majority, they don't work. But the issue is, if they don't work, what is the alternative, right? In many of the areas where people seek these alternatives, it's not because they don't want to address these issues with better medicine and better science, is that they have no alternative. So to my mind, we have a lot of things to do with medical responses. We have to ensure, as I think it's Eugene Rulu has shown in his one of two of his papers, that we get the right quality of antivenoms. There's this whole issue of, the supply of antivenoms that don't work, and fake antivenoms, or antivenoms that are that you need massive doses to be able to get the results. So I think that this symposium has taught me a lot. If a lot of the people on this call in this symposium still made mistakes and gave the wrong answers to some of the questions, and I must say that I was too ashamed to participate because, frankly, I didn't know the answer to some of those questions. Now, if a lot of people made those mistakes, you can imagine what the general understanding in the broader public would be, right? Now, I think we have a lot of work to do on communication, greater awareness. We need to get this in the forefront. We have to mobilize to get this more attention. And finally, I would say that we need to also place this in practical terms, if I may, and I've gone on a bit, but this is the critical point that I'd like to make here. It's all right to say that this is a problem and we need to find a solution and we need resources. But unless we are able to base it on some economic or financial platform, it'll be very difficult to generate those resources. What I've learned in my career is that it is necessary to say, these are the kind of costs we face, these are the fiscal implications, these are the commercial implications, these are the supply chain implications. What I'd like to see running alongside all the wonderful work that's being done on prevention of snake bites, on treatment of snake bites, on interventions in snakebite care, is also greater work on the commercial aspects, the economic aspects of the implications of snake bites to communities, to societies, to individuals, to the absence of livelihoods, impact on labor markets, etc. So, if we do that, then we'll be able to push the agenda with regards to the private sector participating with the public sector to raise resources to try and solve this problem. So I'm encouraged by this symposium. I would like to assure you that I raised this at the board meeting in Nairobi when I was in Nairobi 2 days ago at AMREF, and I raised it with Gitinji Gitahi, who's the CEO of AMREF, and we said that we would like to even do more in this area and work with all the partners that we can find to work on this very important issue. So I thank you very much for inviting me to participate. I'm grateful. Thank you.
Thank you very much indeed. So I thought it would be fitting to close this event, leaving you with something very special to think about. Chloe Vasquez, a wonderful young lady whom I met recently at Watamu Snake Farm and who is making a remarkable impact in the world of snakebite awareness, has written an inspiring poem. I've asked her to share it with us this evening. Chloe, please can you share your beautiful poem with us as we finish up tonight's proceedings?
Yes, so thank you very much, Ali, for inviting me, for organizing this incredible workshop. And thank you to Daktari Online for hosting this, to our sponsors and AMREF for making this event possible, and to our speakers for sharing such condensed and key knowledge. So just a small introduction. For those of you who don't know me, my mom also suffered a venomous snake bite from a pit viper. And from her experience and luckily her survival, because she had very quick access to anti-venom and to high quality snakebite care, I realized that snakebite is neglected across the world. And very few people have the privilege of getting quick access to snakebite care. So despite the severe neglect of this issue, just like Mr. Charles was mentioning, all of you are taking the first step forward to making a change in this neglect. All of you have the power to change the future of your patients and to save mothers like my mother, to save children, to save fathers, to save friends. So thank you all for your attention. I hope that you've learned a lot. And I dedicate this poem to all of you who are at the front line. This poem is called For a Death to Count. For a death to count, must you see it happen? Must it be loud? For my death to count, must I hold the right passport, wear the right skin, earn the right wage? We watch the wealthy age gracefully, their ailments treated carefully with calculated skill. We know when politicians fall sick. We cry out when our beloved celebrities suffer from cancer or AIDS. We bring flowers to our loved ones, sit patiently by their bedsides, fingers intertwined through the beep of the monitor. Meanwhile, beyond the cities, hundreds of thousands suffer, and their moans fall on deaf ears. If I die young, a pointless and preventable death, who will rage? Who will weep? If I were born in a different body, would the world still see me? Or would my death echo violently silent, my scream swallowed by indifference, a victim of apathy? We turn our heads from suffering because it is ugly, because it's frightening. At what point does inaction make us complicit? Are we afraid to contemplate the countless woes of the world, or is it simply too inconvenient? It's time for us to challenge the metrics of importance, to listen carefully, to unite in action. Because silence is a sharp knife, and apathy is terribly outdated, don't you think? So thank you all for this, listening to this poem. Thank you all for being a part of the group who takes a step forward to change this situation, for paying attention to these patients who deserve quality care and access to quality medicines. So thank you all for your attendance, and thank you, Ali, for your invitation.
Thanks, Chloe. That was really beautiful. I love that poem. I just want to say a million thank yous to her for all of your certificate requests and CME point requests and endless emails. They've been amazing, and I'm sure eventually everything will get sorted, but they've been dealing with over 1,000 people a week, and that has been a lot. So thank you to Daktari Online. This has been fantastic, and you've really helped us to make this a success. I really appreciate it.